Hello, everyone, and welcome to today's presentation. I'm excited to have you here. We'll be exploring a comprehensive overview of respiratory anatomy and neural control. The title of our session is Comprehensive Overview of Respiratory Anatomy and Neural Control, with a focus on integrating nervous system regulation, thoracic mechanics, and muscular function in breathing. Over the course of this presentation, we'll cover how these systems work together to enable effective respiration. So, let's get started and dive into the fascinating world of respiratory physiology. Let's take a closer look at the central nervous system, which includes the brain and spinal cord. This is the main control center for processing and transmitting signals that regulate lung function. Essentially, it helps coordinate how we breathe and respond to different needs. Next, we have the autonomic nervous system. This part controls the involuntary smooth muscles in our airways. It's responsible for regulating breathing without us even thinking about it, making sure that our lungs operate smoothly during rest and activity. Now, when we consider nervous control of the lungs, one key concept is dual innervation. This means our lungs receive signals from both the sympathetic and parasympathetic nervous systems. This dual control allows us to breathe both voluntarily, like when we choose to take a deep breath, and involuntarily, automatically adjusting to our body's needs. This flexibility is crucial for adapting to different situations, whether we're resting or exercising. Finally, the somatic nervous system plays a role in voluntary control. It innervates the skeletal muscles of the chest wall and diaphragm, enabling us to consciously control our breathing movements. This is what allows us to hold our breath or speak while breathing. Overall, these systems work together seamlessly to ensure our respiratory process is adaptable, efficient, and responsive to both conscious and unconscious demands. Let's take a closer look at the impact of phrenic nerve injury. When the phrenic nerves are damaged, whether due to surgery, trauma, or disease, it can lead to paralysis of the diaphragm. And as you know, the diaphragm is the main muscle responsible for breathing, so paralysis here can severely impair breathing efficiency. Now, where do these nerves come from? The phrenic nerves originate from the spinal segments C3 to C5, which are located in the neck and upper chest region. Their primary role is to provide motor innervation to the diaphragm, essentially telling it to contract and relax during breathing. An important point to remember is that even if the diaphragm is paralyzed, breathing can sometimes still continue. This is because of the role of other structures, like the intercostal nerves and muscles between the ribs. If these remain functional, they can help facilitate breathing, acting as a backup system. So, understanding these neural pathways and their potential for compensation helps us grasp the complex control of respiration, especially when injury occurs. It also underscores the importance of preserving nerve function during medical procedures to maintain effective breathing. Let's take a closer look at the phrenic nerves and the cervical plexus. The phrenic nerves exit the cervical nerve plexus at the levels of C3, C4, and C5, which are crucial for controlling the diaphragm. This is why injuries above C3 can be so devastating. They can result in paralysis of the diaphragm and all the muscles involved in breathing. Now, moving on to the role of intercostal nerves. They innervate the muscles between the ribs, and these muscles are vital for the mechanics of breathing. They assist in expanding and contracting the chest during respiration. Connecting these points, the cervical nerve plexus and intercostal nerves work together to facilitate effective breathing. When we consider spinal cord injuries, especially those above C3, the impact becomes even more significant. Such injuries can cause severe respiratory problems, including paralysis of the diaphragm and ventilatory muscles, which can compromise the patient's ability to breathe independently. Understanding these neural pathways and their vulnerabilities helps us appreciate the importance of protecting these structures and managing injuries appropriately. Let's take a closer look at the thoracic cavities. The thorax is divided into two main parts, the left and right pleural cavities, which each house a lung. Inside the thorax, there's also an important central division called the mediastinum. This area contains vital structures like the heart, great vessels, and other critical components. Moving on to the thoracic structure itself, it's made up of several key elements: the rib cage, intercostal muscles, vertebrae, sternum, and diaphragm. These components work together to not only protect our vital organs, but also enable us to breathe effectively. The rib cage provides a sturdy shield, while the intercostal muscles assist in the mechanics of breathing. The diaphragm, often called the main breathing muscle, plays a crucial role in creating the negative pressure needed for inhalation. Understanding the anatomy of the thorax is essential because it ties directly into the overall function of respiratory control. The thorax's design isn't just for protection. It's also a dynamic structure that facilitates the essential movements involved in breathing. This dual role underscores the importance of thoracic anatomy in maintaining efficient respiratory function and overall health. Let's take a closer look at the structure of the ribs. There are 12 ribs that slant downward toward the front, and this specific arrangement is crucial because it supports both the flexibility of the thoracic cage and provides protection for the organs inside. Moving on, the upper 7 ribs, known as the true ribs, attach directly to the sternum through their own individual cartilage connections. This direct attachment creates a stable and secure structure for the upper part of the thorax, which is essential for effective breathing and movement. Now, the ribs numbered 8 to 10, often called the false ribs, connect to the sternum not directly, but via cartilage that links them to the ribs above. This cartilage connection introduces a bit of flexibility in the middle part of the thorax, allowing the rib cage to expand and contract more easily during respiration. Finally, we have the 11th and 12th ribs, known as floating ribs because they don't have any anterior attachment to the sternum or other ribs. These floating ribs contribute to the mobility of the lower thorax, allowing for a greater range of motion and helping to accommodate various movements and breathing patterns. All these structural features work together to support not just breathing, but also the overall stability and flexibility of the thoracic cage. Let's take a closer look at the location of the costal groove. It's found on the underside of each rib, and this specific positioning plays a crucial role in protecting important structures. The groove acts as a safe passage, essentially a protective channel, for nerves, arteries, and veins that run along the rib cage. Now, understanding this is especially important in medical procedures. When inserting needles or tubes between the ribs, it's vital to position your instruments just above the rib. This careful placement helps avoid damaging the nerves, arteries, and veins tucked away in the costal groove. So, what makes the costal groove so important? Its protective role cannot be overstated. By being strategically located on the underside of the rib, it minimizes the risk of injury to these vital structures, ensuring both safety and effectiveness during medical interventions. In the context of respiratory anatomy and neural control, knowing the anatomy of the costal groove helps us appreciate how the body is designed to safeguard its critical components while allowing necessary medical access. Now, let's take a closer look at the mechanics of rib movement during breathing. The rib heads rotate on their vertebral articulations, while the vertebrae themselves stay stationary. This rotation is crucial because it allows the ribs to move upward and outward, which is necessary for expanding the chest cavity. Moving on to the structure of the sternum, it's made up of 3 parts: the manubrium at the top, the main body, and the xiphoid process at the bottom. These components form the central part of the chest and play a significant role in the mechanics of breathing by connecting with the ribs. When we breathe in, the sternal ends of the ribs move up and down. This movement increases the volume of the thoracic cavity, making space for the lungs to expand. Without this coordinated movement of the ribs and sternum, effective respiration wouldn't be possible. So, in essence, the rotation of the ribs and the movement of the sternum are vital components that facilitate our breathing process, allowing air to flow in and out efficiently. Let's take a closer look at the pump handle movement. This is another key rib movement that plays a crucial role in breathing. Essentially, it causes the ribs to elevate at the front or anterior-posteriorly, which increases the front-to-back dimension of the thoracic cavity. This movement really helps expand the chest in that direction, making room for air to flow in. Now, moving on to the bucket handle movement. This involves the lateral or side-to-side elevation of the ribs. When the ribs move this way, they effectively increase the transverse or side-to-side diameter of the thorax. This movement complements the pump handle action, and together, they facilitate a more efficient expansion of the thoracic cavity during inspiration. When we consider both the bucket handle and pump handle movements together, their role in breathing becomes even clearer. These rib motions generate pressure gradients within the thoracic cavity. And as you know, creating these pressure differences is essential for air to flow into the lungs, allowing for proper ventilation. So, in essence, these movements are not just about rib mobility. They are vital mechanisms that enable effective breathing by regulating the pressure changes needed for air exchange. The diaphragm is really the star of quiet breathing, acting as the main muscle that drives inhalation when we're at rest. It contracts and flattens out, creating the negative pressure needed to draw air into the lungs. Alongside the diaphragm, the peristernal intercostals play a supportive role by helping to stabilize the rib cage during inspiration, ensuring that the chest wall moves efficiently. The scalenes also contribute by elevating the first two ribs, which further assists in expanding the thoracic cavity during normal, restful breathing. These muscles work seamlessly under normal conditions, so we often don't even notice their activity. Now, when we look at the primary muscles involved in quiet breathing, the scalenes and sternomastoids come into play during inspiration to help increase airflow. The pectoralis major, although more often associated with arm movements, also helps expand the chest cavity during breathing. On the expiration side, the abdominal muscles come into action by pushing the diaphragm upward, aiding in pushing air out when we exhale. These muscles are usually recruited during times of increased respiratory demand or distress, like during exercise or respiratory illness. Finally, when breathing becomes more demanding, accessory muscles step in. These include both primary ventilatory muscles and other additional muscles that assist in increasing the work of breathing. They ensure that the body can meet higher oxygen demands, supporting effective ventilation under stress. Understanding how these muscles work together helps us appreciate the complexity and efficiency of our respiratory system. Now let's take a closer look at the anatomy and structure of the diaphragm, focusing on its key parts. First, we have the crural part of the diaphragm. This section originates from the lumbar vertebrae, specifically L1 to L3. From there, it forms the left and right crura, which are essential components that help anchor the diaphragm to the spine and provide stability. Next, we move to the costal part of the diaphragm. This part originates from the lower ribs and the lower part of the sternum. These fibers not only contribute to the overall shape of the diaphragm, but also play a crucial role in its function during breathing. Both the crural and costal parts come together at a central point known as the central tendon. This central tendon is like a connective hub that allows the diaphragm to function efficiently. It also divides the diaphragm into right and left halves, called hemidiaphragms. Speaking of which, the diaphragm is structurally divided into two hemidiaphragms, right and left, thanks to this central tendon. Understanding this division helps us appreciate how the diaphragm coordinates with neural control and how it contributes to respiration. Connecting all these points, you can see how the diaphragm's anatomy is perfectly suited for its role in breathing, with specific parts working together to facilitate movement and stability. Let's take a closer look at the role of the crural fibers. These fibers contract specifically to increase the vertical dimension of the thorax during breathing. What's interesting is that they don't attach to the ribs at all, so their primary focus is on expanding the chest vertically, which helps draw air in. Moving on to the costal fibers, these play a different but complementary role. When they contract, they help lower the dome of the diaphragm and lift the lower ribs. This dual action increases not only the vertical, but also the lateral dimensions of the thoracic cavity, making more room for air to enter. And of course, the diaphragm itself is central during inspiration. Its contraction is coordinated to efficiently expand the thoracic volume. This expansion is what allows air to flow into the lungs. It's a perfectly synchronized process that highlights the elegance of our respiratory control system. Together, these muscles and fibers work in harmony to ensure effective breathing, which ties back to our overall theme of understanding respiratory anatomy and neural control. Let's take a closer look at the role of the diaphragm in controlling thoracic volume and pressure. During quiet breathing, the diaphragm moves about 1.5 centimeters. This small but essential movement allows roughly 500 milliliters of air to enter the lungs with each breath. Now, when the diaphragm moves downward, it causes a three-dimensional increase in thoracic volume. This expansion is what primarily generates the subatmospheric pressure needed for inspiration. In situations where there's an extreme demand for air, such as during vigorous exercise, the diaphragm's movement can increase significantly, ranging from 6 to 10 centimeters. This larger movement helps meet the body's increased oxygen needs. The key point here is that the diaphragm's movement is vital for creating subatmospheric pressure, which is the driving force behind inspiration. Without this movement, it would be much harder to draw air into the lungs efficiently. So, understanding how the diaphragm works at different levels of demand really highlights its central role in respiratory mechanics. Let's take a closer look at the diaphragm's function during exhalation. During passive exhalation, the diaphragm is actually mostly inactive. This means it doesn't need to work hard to push air out. However, early in exhalation, a little muscle tone is maintained to act as a sort of braking mechanism, helping control the process smoothly. Now, an important force at play here is the elastic recoil of the lungs. When we exhale passively, this elastic recoil helps return the diaphragm to its resting position naturally. This recoil is essential because it makes the transition between inhaling and exhaling seamless and efficient. This inactivity of the diaphragm during passive exhalation is actually beneficial for maintaining smooth, continuous breathing cycles. Its resting position is perfectly suited to facilitate that seamless shift from inhaling to exhaling, ensuring our breathing remains steady and unlabored. So, the overall message is that the diaphragm's passive role during exhalation, combined with lung recoil, plays a critical part in keeping our breathing smooth and effortless, which ties right into the broader theme of how neural control and anatomy work together to regulate respiration. Let's now look at how COPD and emphysema impact the diaphragm. In these conditions, overdistension of the lungs causes the hemidiaphragms to flatten, mainly because the lungs don't empty properly. This flattening reduces the size of the lower thoracic cavity, which in turn decreases the inspired volume, the amount of air we can draw in. Moving on, diaphragmatic paralysis is another important aspect. When the diaphragm becomes paralyzed, it can lead to what we call paradoxical movement. Instead of moving downward during deep inspiration, the diaphragm gets sucked upward, which actually hampers effective ventilation. Now, considering the broader implications, the consequence of poor lung emptying, like in overdistension, is that the diaphragm becomes flattened. This change significantly impacts respiratory mechanics, making breathing less efficient. Understanding how these conditions affect the diaphragm helps us see the crucial link between lung pathology and neural control, which is central to our overall discussion on respiratory health. Let's take a closer look at the intercostal muscles and their roles in breathing. The parasternal fibers, for example, are responsible for elevating the ribs, which helps us during inspiration by expanding the thoracic cavity. Conversely, the interosseous fibers depress the ribs, assisting with expiration by helping to decrease the thoracic volume. Interestingly, these fibers have dual functions. They can both elevate and depress the ribs depending on the phase of breathing. Their activity becomes especially important during forced breathing, when we need to increase airflow beyond normal resting levels. Moving on to the internal intercostals, these muscles contract to elevate the ribs, again aiding inspiration. But their primary role is during forced breathing, not passive breathing, because they help significantly in expanding the chest when we need a stronger respiratory effort. they don't play much of a role during relaxed, passive breathing, where the process is mostly driven by diaphragm movement. Finally, the external intercostals are also crucial. They support breathing by assisting in elevating the ribs during inspiration. So overall, these intercostal muscles work together intricately to support both resting and forced breathing, ensuring our thoracic cavity can expand and contract effectively. This coordination is fundamental to our respiratory mechanics and highlights how complex and well-regulated this system really is. Let's talk about activity during breathing. Typically, the scalene muscles are quite relaxed when we're at rest, showing minimal activity. However, as the effort to breathe increases, such as during exertion or respiratory distress, the activity in these muscles ramps up significantly. Now, regarding where these muscles attach, scalene muscles connect to the first and second ribs. This attachment is important because it allows them to assist in expanding the thoracic cavity, aiding our respiratory mechanics. Essentially, they help elevate the ribs during deep or labored breathing. Finally, the activity of the scalene muscles can serve as an important indicator of respiratory health. When we see elevated activity at rest, it often points to respiratory distress. This increased activity suggests that the body is working harder to meet oxygen demands, which is a key sign to recognize in clinical settings. So, understanding these muscles, activity, and their role helps us assess how well someone is breathing and whether they might be experiencing difficulty. Let's take a closer look at the origin and insertion of the sternomastoids. These muscles originate from the manubrium of the sternum, which is the upper part of the breastbone. From there, they insert on the mastoid process of the skull, that bony prominence just behind the ear. Now, their role in resting inspiration is quite interesting. When these muscles contract, they elevate the sternum and the anterior ribs. This movement helps expand the thoracic cavity, making it easier for air to flow into the lungs even when we're at rest. It's important to recognize that the sternomastoids are not just accessory muscles for head movement. They also play a vital role in respiration. During increased respiratory effort, such as during exercise or respiratory distress, these muscles become more active. This increased activity highlights their significance in aiding respiration, especially when the body needs to breathe more deeply or efficiently. So, in essence, the sternomastoids are key players in both normal and increased breathing efforts, linking their anatomical features directly to their functional importance in respiratory mechanics. Now, let's explore the role of the pectoralis major in elevating the ribcage. When the arms and shoulders are fixed, this muscle plays a crucial part by lifting the sternum and the ribs. This action is particularly important because it helps expand the thoracic cavity during inspiration, making it easier for the lungs to fill with air. Looking at its anatomical connection, the pectoralis major extends from the sternum to the humerus. This positioning allows it to contribute to respiratory mechanics, especially when the arms are stabilized, acting as an accessory muscle of breathing. This brings us to its significance in patients with COPD. In these individuals, the pectoralis major becomes notably active, especially when they adopt the tripod posture, leaning forward with hands on their knees or a surface. This posture helps them utilize the muscle more effectively to assist in inspiration, compensating for their compromised lung function. Overall, understanding this muscle's role highlights how accessory muscles work together to support breathing, especially in respiratory conditions. Let's talk about the role of abdominal muscles in respiration. The key point here is that the abdominal muscles, especially the rectus abdominis, are the only accessory muscles involved in expiration. When they contract, they compress the abdominal cavity, which in turn increases the internal pressure. This pressure helps to push the air out of the lungs during exhalation. Now, during normal, quiet breathing, these muscles are actually inactive. They don't play a role in everyday exhalation. Their involvement is only necessary during specific conditions, such as forced expiration, when you need to breathe out more forcefully, like during intense exercise or certain clinical situations. Moving on, the impact of these muscles becomes even more significant in respiratory conditions. For example, in diseases like COPD, airflow resistance is high, making it hard to breathe out. In such cases, the abdominal muscles activate to help overcome this resistance and facilitate effective breathing. So, in summary, while these muscles are mainly involved during forced expiration, they become crucial in conditions where breathing becomes more laborious, helping us maintain proper ventilation even under challenging circumstances.